Thank you. So my name's Emily Hill. In the program, it says I'm Dr. Emily Hill, but I'm not. Maybe some unconscious aspirations there. And I'm going to talk to you this afternoon about the research that I'm doing for my master's thesis, investigating barriers to access and delivery of end-of-life care for persons with dementia in long-term care. So I'm just going to take you through the background about this topic and the literature review that I did, and then give you a bit of information about my study, which is ongoing, and give you some of the preliminary findings that we're looking into. So palliative care and dementia. Palliative care is recognized in the literature as being appropriate for persons with dementia, but it's also recognized that it's very underused, and when it is used, it's of lower quality than, for example, someone with a cancer diagnosis. According to the World Health Organization, palliative care aligns with the person-centered philosophy of dementia care. And palliative care has benefits for not only the individual with dementia, but also families and caregivers because of the huge burden associated with dementia caregiving. Persons with dementia often experience painful and futile end-of-life treatments, for example, feeding tubes, and there's evidence in the literature of unmet pain needs, emotional concerns, and quality of life issues. So clearly there's an issue here. So what I decided to do based on this preliminary information was we wanted to conduct a literature review about why this is still underused. So if it's known that palliative care is beneficial, what barriers exist with regards to palliative care and dementia, and why is this still a problem and what's being done to fix it. So we found around 85 articles from 4 different databases. Most of the information we found was American. And we had a specific focus when we were searching for the combination of palliative care and dementia. So the 4 themes that we found in this literature review were disease trajectory, misconceptions about dementia, lack of education, and policy and funding barriers, and I'll talk more about those in a little bit. We also found very limited information from Canada, which is important to note because obviously our healthcare system is structured differently than the American system. So we actually went outside the literature and tried to do some Googling and some phone calls to see if we could find more information about palliative care for persons with dementia in Canada, and we still found pretty limited content. So the first big theme that we found that was acting as a barrier for good quality palliative care for individuals with dementia was the disease trajectory associated with dementia. So as we heard in the previous presentation, the frailty and the unpredictability of the disease trajectory. So there's uncertainty about how much time is left, and staff often felt that they feared liability if they gave up too early and initiated palliative care too early. And because of this, there was increased use of CPR, feeding tubes, and transfers to hospital. Communication difficulties are also an inherent problem with end-stage dementia because most people dying with dementia are so cognitively impaired that they can't communicate what their needs are. So pain management was a lot more complex because people had a harder time determining what the needs of the resident were. This may always be an issue because the disease trajectory associated with dementia is unlikely to change anytime soon, but it was interesting to note these things. We also found that the view that dementia is not a terminal condition was very common, both among staff and family members. So when individuals were dying with dementia, if they had a secondary condition like a UTI or pneumonia, that was often characterized as the primary cause of death. And because we know how to treat those things, there was a sense that we need to do everything we can to treat that specific issue, even if they were dying with dementia anyways. Sorry about that. The next thing we found was educational barriers. So there's people who specialize in dementia care and there's people who specialize in palliative care, and they often don't specialize in both and often don't communicate with each other. And that was a barrier to good quality care. So palliative care could still happen, but palliative care for persons with dementia was not often as good. The needs of persons with dementia are similar but not identical to those with cancer, especially with regards to communication difficulties. And assessment tools, most assessment tools for palliative care were based in oncology, so they often don't reflect the needs of individuals with dementia. And then the last big theme that we found was funding and policy barriers. So funding incentives and policies that often work against the goals of palliative care. So again, most of this information was American, but likely this was due to misconceptions about the nature of palliative care or about the nature of dementia. We found that resource use, because someone dying with dementia often has a more unpredictable death, there was a sense among staff that if we don't have enough resources, we should use them on someone who is going to have a more predictable death, and they would ration those resources in favor of cancer patients. And it was felt that individuals with dementia sometimes didn't deserve palliative care resources the same way. There was also, in the US, we found in the literature a requirement of a 6-month terminal diagnosis to be eligible for some funding for palliative care. And dementia often rarely fits this category of, we know for sure that you're going to die in the next 6 months. And reimbursement policies often complicated palliative care delivery, and if something was more complicated, it often didn't happen. So based on this knowledge, we decided to structure my study around gaining a greater understanding of how palliative care works for individuals with dementia in long-term care in Ontario, specifically when it's initiated and who makes the decision, guidelines or assessment tools that aid in the delivery of good quality care, and policies or funding incentives that facilitate or prevent palliative care from occurring. So my study is ongoing. It's a qualitative study focusing on the experiences of staff delivering palliative care to persons with dementia in long-term care. And we chose to focus on the experiences of staff because we were looking at delivery of care. I think the experiences of family would be a very important piece as well, but for this study we chose to focus on staff. And we focused on long-term care because that's where most individuals who are dying with dementia are located. So we've conducted semi-structured one-on-one interviews, and we're doing content analysis of these interviews using a phenomenological lens. So we, again, use staff and volunteers in long-term care settings. We've had a snowball sample of various disciplines, and that was important because we wanted to gain a broad picture of how the care was delivered. So we've had RNs, RPNs, nurse practitioners, PSWs, palliative care volunteers, physicians, pharmacists, and chaplains and social workers. So currently we're at 19 participants. We're still in the data collection phase, so we're hoping to get more. And currently we have 7 facilities. So some of our preliminary findings, I sort of grouped these into 4 themes. Are communication difficulties impeding the delivery of palliative care, that there's few guidelines to aid staff in providing palliative care for individuals with dementia. There's inconsistencies in when palliative care is initiated, and there's not enough resources, especially for more holistic measures for someone with dementia at end of life. So one of the things that we found is the lack of ability to communicate means uncertainties in pain management and other needs. So we had one participant tell us it's very difficult to do an assessment on them because they can't really tell you. So it's all getting to know them and their personality and doing an assessment based on changes in behavior rather than listening to what they're saying because you're not sure what they're saying is right. And we also determined a lot of nervousness about what the right course of action was when you couldn't confirm that with the resident or the individual. One person told us, I think one of the biggest challenges is the fact that they can't communicate what's going on. Like in the early stages of palliative care when they're still able to communicate, so meaning someone without dementia, you don't have that with a dementia patient. They can't express, they can't tell you they're having pain. So you're looking for these other triggers and just wanting to make sure. The next big thing that we're finding is that there's not a lot of guidelines to aid in the delivery of palliative care specifically for individuals with dementia. We heard that people don't have anything formalized, and what we're finding is that each facility is sort of coming up with their own policies and making their own system, but it's different for every facility. and staff are using their own judgment to determine when palliative care is started. There isn't always a standardized protocol or test that they can use, so it varies between facilities. Some facilities have a physician has to give that order that they're palliative. Other facilities, the RNs will decide when it's best. So we had one individual tell us we usually look at the resident, and if you see them deteriorating, all of a sudden they're not eating or drinking for a number of days, or if they develop pneumonia and they're really quite ill, I think at that point you sort of get together with a doctor and discuss it, and obviously you get the official write-up. You don't just let them suffer. We also found that there was an inconsistency in initiation for palliative care. So as I mentioned earlier, many resources like extra pain drugs, palliative care carts, palliative care volunteers, those are only made available when you have that official palliative designation. And you're missing out on some of those resources if that designation happens too late. So we had one individual tell us that it was way too late. It's difficult to prognosticate end of life. Until the doctor deems them palliative, they don't get the extra supports and medications they need at end of life. And people also indicated that it varied case by case, and it was difficult to determine sometimes when palliative care would be best for an individual with dementia. Someone said it's not like there's a blood test that you can get that says they're palliative now. And then the last big thing that we're finding is there's a lack of knowledge and resources. So often individuals who work in long-term care don't have specialized training in palliative care. Sometimes the facility is relying on grants to get their staff educated. There's not everyone has had palliative care training. So we had one individual say the challenge is having the time and staff available to figure out what those individual needs are. So she mentioned if you're dealing with agitation, you could give them one-on-one time, or you could give them medication, and often you would like to do both or like to spend more time with the resident, but they just don't have time. Long-term care is so task-oriented that there's not enough staff to spend that extra time with the individual. And we noted that a lot of staff members were really distressed about this, about knowing that they were leaving the room and that individual was going to die, but that they had somewhere else they had to be, something else they had to do, and they couldn't spend that extra time with the person. And then again, I find sometimes that the biggest barrier that I see from a staff point of view is staff just want to go in and do their thing and get out, because long-term care, we're so time crunched. They don't often take that extra time to give a little TLC. I think that sometimes prevents the palliative care experience from being a positive one. So moving forward with these findings, obviously this is an ongoing study, so we will hopefully have some more findings from this. We're hoping to increase the sample size, we're hoping to be able to provide recommendations between facilities. So right now, each facility is kind of operating on their own, and we have seen some collaboration between some of the facilities, but we're hoping that we can share this knowledge amongst other facilities and continue to add information to this field, because this is an emerging issue in the literature. There's a lot of studies internationally that are now beginning to address this. There's a big study in Europe going on right now about this same issue and trying to increase palliative care participation for individuals with dementia. And as the population ages, the number of people with dementia is going to increase, and they're all going to end up in long-term care. So efficiency and high-quality care is going to be even more important. The resource shortage is always going to be an issue. We've acknowledged that, so it's going to be important to come up with ways to deliver this care efficiently. And more research is definitely needed. And as I mentioned at the beginning, the experience of families and caregivers, I think, would be a really important piece to add to this issue, because I think that they would have a lot to add to this. So I'd just like to acknowledge the contributions of my supervisor and my committee members and all the individuals who've given us their time to participate in this study. Thank you.
Thank you, Emily. Our final speaker